Now, what I'd like to do now is to move on how I approach heart failure. So I'm going to move this out of the way, and hopefully we'll do heart failure. Now, heart failure is this abbreviation of CHF. I don't like abbreviations because sometimes there's so many of them, but heart failure is one of the symptoms. And if you take somebody, how would you imagine somebody progressing into chronic heart failure? Now, there's always acute heart failure, and there are lots of aspects of heart failure which are difficult, but I always ask these questions. One, I start with how is your exercise activity? How is your functional capacity? What do you do? So exercise capacity. What could you do last year that you can't do this year? Then I move into, I imagine that the next thing is dyspnea on exertion. Again, I apologize for the abbreviation, but I'll put dyspnea on exertion. That is, what limits you? Do you find yourself unable to walk? Is it because you pant and are short of breath? There are all sorts of issues with dyspnea on exertion. Then, classically, I believe that they move to paroxysmal nocturnal dyspnea. Again, I apologize for the abbreviation, PND, paroxysmal nocturnal dyspnea. That's that time in which the patient wakes up at night and feels that they are so short of breath that they need to sit up on the side of the bed. And Frank Netter says that he's had patients walk to the window and open it up. I have never had a patient ever do that or tell me about that. But it's always worth asking. And what the principle behind that is that when they stand up, you unload the ventricle. What does that mean? That means that takes away the preload, and it means that the heart doesn't have to pump as much, and the lungs aren't feeling the backup in their left atrium from the left atrial pressure that's higher, and they breathe easier. Now, that's distinguishable from sleep apnea, in which they've suddenly woken up after apneic spell, and then they wake up suddenly, and then they just roll over. And it's different than the COPD bronchitic, who gets that phlegm in his throat or her throat, coughs and gets rid of it, and then just rolls over. The PND, or paroxysmal nocturnal dyspnea, is that episode where they just feel profoundly short of breath, and it doesn't go away in a minute. It takes time to unload that ventricle and have things normalize. Now, sometimes nocturia is about at the same time, because the principle for both of them is about the same. What happens in theory is that you resorb your interstitial fluid. It starts, the kidneys start working overtime. They filter out, and you have to wake up at night to urinate. Or you have to sit up in bed because you have plethora in your lung fields and you're short of breath. So these two often happen at the same time. Then as you march further and further into chronicity, you might get orthopnea. Orthopnea is not so long a phrase, so I won't abbreviate that there. And it is where they have to prop themselves up slowly but surely, more and more, to the point where they can't lie flat. And it has to do with not a comfort, it's just they just can't lie flat because they get short of breath. Now that's different. Most people will say that they have two-pillow orthopnea, but it comes from propping their head forward. It isn't about being short of breath. If they suddenly had those two pillows removed, they just feel uncomfortable. But it's not shortness of breath. If you remove the pillows and had them lie flat, they get immediately short of breath. Then the favorite one, of course, is edema. Edema is this vague filling of fluid in your legs or anywhere where you can pit. Patients will frequently notice that they have sock line edema, but there are lots of causes of edema, ranging from diabetes, obesity, and much to my chagrin, old age. So all of these can happen with edema, but heart failure sometimes adds to that. I add in cough. This is where it's suddenly gotten very bad. Cough, that means that their lungs are filling with fluid and they have to sit up and cough and get rid of it. And sometimes I add in hemoptysis, which is truly pulmonary edema at its worst, and in acute heart failure you'll frequently have that happen. The most important part of the history in heart failure for me is weight. Weight is just crucial. Sudden weight gain. If you gain 10 pounds in a week, that's fairly prominent weight gain. You would have to eat 70 Big Macs in addition to your normal diet to gain 10 pounds of weight. Now, the caveat there is that people will gain weight from high salt foods and a high salt diet. So you have to be careful with that. But sudden weight gain is a big question that I have in heart failure.